Yep.
Yes.
Okay,
Great. I'm going to get going with the topic tonight. Femur fractures, I'm not going to go through the basics with you. I think classification and ATLS principles are something that you should know by the time you finish intermediates, but if you have any questions regarding those, so I've picked a few topics around femur fractures and distal femur fractures that I think are relevant and sort of topical for the moment, and we're going to address them as a case-based scenario for most of the cases, for most of the topics. If I ask you a question, please switch on your video and unmute yourself. If you're not responding to a question, just put your hand up and I'll try keep track of what's happening on the Zoom call. If I miss a hand up, we'll get to questions at the end, so hopefully won't miss anything out. All right, so objectives and outcomes that I've outlined here in this talk. We're going to talk very briefly about the relevant anatomy, and that's surgical anatomy. And then we're going to go through segmental femur fractures, subtrochanteric femur fractures, which we all love, periarticular fractures. I'm going to briefly look at atypical fractures of the femur, and then again, fragility and periprosthetic distal femur fractures. Now, I know that you have fragility fractures as a topic on its own, so I'm not going to spend a lot of time on classification, but we will look at a few cases and what the kind of teaching is with regard to that. So in terms of relevant anatomy, there are a few things around the femur that are really important to ensure that the patients have union and function, which is our objective with all orthopedic operations. And mechanical alignments is key. Attention to detail with regard to rotation is essential, especially when you're using things like traction tables or you've got a patient in a position that you're not used to. And then, as you can see, the T-shirt here says thou shalt not varus, and that's important, especially around the subtrochanteric, anywhere really in the femur, but around the subtrochanteric area that we're talking to today. We're not addressing neck of femur fractures. So I just wanted to ask Vabrant, can you tell us about the numbers for mechanical and anatomical alignment with the femur? I'm not hearing you.
I'm trying.
Oh, there we go. Got you. Right.
Kirsty, this is something I read up before every case. This is not something that I know by the top of my head. But for mainly, thou shalt not varus.
Mm-hmm.
For distal femur, we're looking at 87 degrees.
Mm-hmm.
At the lateral distal femur angle.
Mm-hmm.
And proximal 130 degrees for your femur neck angle.
Yeah. So we're going to go through a couple of those angles. The difference between your mechanical and anatomical axis is important for where you put your, where you want to have your femur line up, especially in those where you've got comminuted femurs. So thanks, Vabrant. Just looking at the distal femur to start with, and then we'll move on to those other angles. Your lateral X-ray for putting in retrograde nails and distal femur locking plates and ensuring that you have anatomical reduction of your distal femur. It's important that you get a true lateral of the distal femur, and you all know about Blumenthal's line, the posterior condyles, and then the anterior and posterior cortices of the distal femur, and that's important largely for your entry for your retrograde femur nail, but also for where you put your screws in with distal femur plating. And X-ray, attention to getting your X-ray right is really important. And then we've said this 100 times, and we'll say it 100 more times in the trauma meeting. You must remember the box of the distal femur, right? So Skulk Funimavo, on this X-ray, on this little drawing of the distal femur, which side is medial and which side is lateral? The drawing, not the X-ray.
Yeah, so the 25-degree angle is medial. The lateral is the higher of the two with a lesser angle on the slope.
And why is this important?
So it's especially relevant, as you mentioned, when doing distal locking. It's important to note that the screw, you will not see with a true AP, you will not see the tip of the screw typically as one would normally do with for example, a distal tibia. So if the screw, it should look short essentially. If it looks like it's extending past the far cortex, you can assume that you've gone way too far, and then that commonly can cause irritation in the structures of the medial distal femur.
Yeah.
Yeah.
Good. Cool. Thank you. All right. So I have to say, when I wrote exams, I had this little piece of paper up on my toilet bathroom wall so that I could, as Webran said, look at the angles. And important, before you go into a theatre case, you're doing a retrograde nail and you're not sure about alignment, to look at the differences between the angles. The mechanical lateral distal femur angle is around 81 degrees, and the anatomical lateral distal femoral angle is around 88. And the difference between the two is important as to which, you're putting a nail up the anatomical axis, but that can affect the mechanical axis and the difference between the two. And then also just remember, especially with putting screws up the neck and proximal femur fixation, your femoral anteversion, with regard to where your screws should be. And then just the joint line angles are important as well. If you've got fractures on both sides of the joint, you want to try and restore anatomical structures. All right. So if you don't have a copy of this, I'm happy to send this to you. Really helpful little pocket card to have on your desktop or printed out to keep with you. All right. Francis, are you online?
Yes, hi, Kirsty.
Hi, Francis. All right. So this is a 21-year-old male patient involved in a motor vehicle accident. We're going to exclude all the ATLS principles because the patient's stable and his hemodynamic okay, HB is all right. We're going to move with all the cases we discussed tonight. I will repeat this, and those are the important things when you're looking at a patient in casualty. But for the purposes of tonight, we're going to discuss surgical options. All right. So how are you going to approach this? What do you see, and how would you fix it?
Okay, sure. So you've got what looks like two APs of the proximal femur and a lateral showing down to the knee. The patient has three distinct fractures. First is the neck of femur, basicervical, and subcapital, both of which appear to be minimally displaced. Obviously, I'd need to have a look at a lateral to assess the displacement well of those neck of femur fractures. And then a lower fracture in the subtrochanteric region, extending down into the shaft. It's got some comminution. This one is angulated and varus. It's not reverse oblique, but it's got a medial fragment which seems not to be attached to the rest of the shaft, so that might make the reduction a little bit difficult, or getting good fixation.
Yeah, okay. Just for the purposes of this discussion, I don't think there are two neck or femur fractures. I think the transcervical is
just the acetabulum
posterior wall.
Okay. Okay.
I agree.
That makes it a bit easier.
So just the two fractures for the purposes of this.
Okay. Sure, yeah. So this obviously requires fixation, slightly easier, only having one neck or femur fracture. So I would try to fix this with one device, being a ketalomedullary nail. Very important during setup to assess the reduction, particularly of the basicervical fracture on the traction table, hopefully not displacing it, but good views, good lateral, maybe oblique lateral views to make sure it hasn't been displaced when placing the patient, and then possibly some provisional fixation percutaneously with wires to stabilize that a little bit. And then I would do like I said, a capillomedullary nail entry points, standard entry points at the tip of the trochanter. Young patients, so something suitable for harder bone, not for osteoporotic bone. Possibly a 2-screw construct into the head and at least 2 distal locking screws, because it's not a length stable fracture in the shaft.
Would you consider anything else here?
There has previously popular for a bifocal fracture like this was the combination of a retrograde nail and a plate and screw construct like a DHS. In this case, I think the more distal of the fracture is a bit too proximal to allow adequate locking for a retrograde nail, and the risk with one device is perhaps you don't do so well with one of the fractures. It's either mal-reduced or doesn't unite as well. But adding complexity to the surgery with 2 devices also has its pitfalls. Just trying to see if there's something you can maybe consider a long lateral locking plate, but I haven't really seen that done in my time.
Yeah, I wouldn't put a locking plate where I can help it in the proximal femur. I would agree with you with your device choice, and certainly not a retrograde femur nail. Yeah, as you say, the fracture ends too high up. We'll talk about the different options and using combined devices shortly. But this was a case that was sent to me with the question, should we use a proximal femur locking plates? And we'll also just discuss why plates are better than nails a little bit later. The issue here is your entry point may displace your neck or femur fracture, and that's your priority. So you may consider even using screws, not just wires, but screws across that fracture. And I'll show you a case where that's been utilized. But obviously that's your concern if you have a very medial entry point, which is what you want to aim for with a subtrochanteric fracture, that you may displace that neck or femur where it's sitting. All right, Dane.
Just the video. Okay. Can you hear me and see me?
Yeah, I can see you. Hi.
Hi. So another series of femur X-rays. They're all there's an AP on the left, and then posterolateral at the knee, at least in the next one. But obviously, there's a lot of things going on there. There again are multiple fractures present. There is a transcervical displaced neck or femur fracture, a comminuted subtrochanteric fracture, markedly displaced, as well as a distal metaphyseal diaphyseal junction fracture, also quite markedly displaced. I don't see any, possibly some extension to the knee. Sorry, as I said that, I saw a fracture line on the medial side on that first X-ray, which extends into the knee. So I'd interrogate that a bit further with additional imaging. However, from what we've got, sorry, just the patient's age as well.
27-year-old motor vehicle
Okay, so
accident.
okay, young patient. So fractures as I've described, and now fixation options.
Then, sorry, just to interrupt you, for the purposes of this, the CT shows no extension into the joint.
Okay,
Into
so
the
no,
knee, into the knee.
the knee joint, yes. Okay, so in this case, as opposed to Francis's, the neck femur fracture is displaced. And again, it would be your priority in terms of fixation. Again, I believe, similar to Francis's case, this could be done with a single device in the form of a cephalomedullary nail. Personally, I would attempt reduction on a traction table, but have a low threshold for opening to reduce this NOF. And then similar again, I would pin it, but as you had said, you could use screws to hold it more reliably. Your entry point wouldn't be such a concern in this case in terms of affecting your reduction, or at least affecting your fracture displacement. And then, yeah, it's going to be one of those where you are not going to get an anatomical reduction of the shaft at all, but you can span it with the nail. And then distally, that looks like the one that's probably the least concern in terms of reduction. And then, yeah, proximal locking, distal locking, not an easy case, obviously.
So you've said traction table. What approach are you going to use for the hip? Sorry, I lost you.
If I'm not able to achieve an adequate reduction via closed, I would attempt closed reduction first with traction table maneuvers, Ledbetter, etc. But it's probably not going to work considering the shaft fractures. So if I can't get it with simple traction alone, I would advocate a Smith-Peterson anterior approach to aid my reduction. And then you can put on a plate through that approach to help maintain the reduction for the neck of femur fracture before you proceed with your nail.
And could you do anything else before you go to open over the neck? Have you seen anyone?
You can try some percutaneous techniques, yeah. Chance pins or blunt, like ball, what do they call them? Ball tip pushers, I think is the term, or ball tip reduction tool. In like a sort of semi-percutaneous procedure to try and push the fragments and help with your reduction. And then you could put either wires or cannulated screws from a lateral position or lateral angle whilst reducing it from anteriorly. And then again, a nail at the end of the day. So you'd have to be aware that where you're placing hardware in terms of not getting in the way of your own fixation at the later point.
Yeah, this is, as you say, a very tricky case, one you want to do with two orthopedic surgeons. The other thing that you really need to pay attention to here is rotation. We've got large segments of bone that are floating. Your rotation is important. So even taking an x-ray of the contralateral side, making sure that when you put your distal locking screws, of which I would probably advocate 3 here in 2 different planes, with that distal extension, make sure that your rotation is, and you may need to use blocking wires distally because that fractures well past the isthmus. So really a complex case, and you've got to have all the tools and an ABC plan, and possibly D&E here. Right. So this is what was done for this case. As you said, 2 screws up the neck where they've used the fracture fixation. If you look here on the CT scan, can you see my mouse if I point on the screen?
Yep, can see it.
Yeah. So if you see here, they've put the nail and the screws on either side quite nicely, but it is rather tricky to do. And so wire placement for cannulated screws may be something that you'd want to consider in this case. But they've reduced it pretty well. All right. So thanks, Dane. We'll have some more cases later on. Segmental femur fractures are, by definition, 2 discrete fracture lines separated by circumferentially intact intercalary bone segment. The technique that Francis was alluding to is a rendezvous technique. We use a sliding hip screw with a retrograde femur nail, and that's a well-described technique. But essentially, your ultimate goal of surgery is to obtain anatomical alignment, which I'll keep reiterating on throughout the course of this evening, provide a mechanical environment to support bone healing, and to achieve that in the least invasive way. Now, sometimes it's not possible, but it is essentially your gold standard of how to treat these segmental fractures. Now, the article that I've quoted here at the bottom, we're going to go through an example through that, but I find it quite helpful where you've got complex situations to break the fractures up and use what they call the cover-up technique, where you look at each fracture separately and look at the gold standard and how you would potentially treat that fracture. And then ask yourself, can you use a device? Is the gold standard the same for each of these fractures? If not, then you should consider using 2 devices. All right. So this is the first fracture. Brad, are you online?
Yeah, I'm here.
If you had this fracture in isolation, what would you consider for fixation? Again, another young, healthy patient, isolated injury to the right femur.
Yeah, so I think at our institution, yeah, young, healthy, it looks undisplaced, at least on that view. It probably would not need an open reduction if it's anatomic in the other views that we have. And then we would consider probably a DHS, so a sliding hip screw construct, or one of the newer fixed angle plate devices.
And could you use a nail for this?
I don't think it's out of the question, but like you mentioned, it then you open yourself up to risk of displacing that fracture that you have now.
Certainly. So if this was an isolated fracture, as you say in our unit, but many units would use a nail. So the outcomes with nailing, if you get your reduction well aligned, are equal. All right. So now you've looked at that fracture. Okay. Next fracture. What are you going to do for this one?
Yeah. Again, so just that in isolation would be an intramedullary nail.
Okay. Fine. And how are you going to do it?
If you're in isolation, it would be dealer's choice, but I think the gold standard is still an antegrade nail, but you could go retrograde.
There's no difference. So you've got both in your arsenal, and then we've got this. So what are you going to do with this fracture?
So it's a distal femur fracture. Looks like partial articular. Does look, yeah, there's a continuation there into the joint, not displaced. So in isolation, I would do an open reduction and a lateral femur plate, fixed angle locking device for that.
So if you were to put these 3, so now this is a segmental fracture with 3 separate fractures, how are you going to manage it?
Yeah. So I think the elegant thing again, and to decrease complexity, would be to try and manage them with a single device, but possibly some other additions just to support your positions that you have here and support your reduction and fixation. So I think you can manage this with a cephalomedullary nail. Just having the addition of at least K-wires plus minus cannulated screws for the neck of femur to keep that position. The nail would be ideal for the shaft fracture, and then distally, I'd probably start by clamping and putting in cannulated screws there up anterior and posterior to the nail to ensure I don't lose that position as well, and even consider a plate going up the side, or a small fragment plate just acting as an anti-glide could work. Or basically a larger plate, and then just keeping my screws unicortical to start to allow my nail to come past, and then coming back to that and seeing if I could get more screws in the sort of miss a nail technique distally. That's what I would do, I think.
I'm not sure that using a single device necessarily decreases your complexity here. And if you were to take your distal femur fracture in isolation, you'd said you'd like to have a plate on it, but it's complex because there are 3 fractures now. Would you now? So if you were to fix this with just cannulated screws, which is what you're saying you're going to accept with a cephalomedullary nail, but this fracture, all that it's going to have in it is cannulated screws, would you allow your patient to wait there?
No, not just with the cannulated screws. Yeah, I would definitely want the addition of a lateral plate there to act as a buttress and an anti-glide. I'm not sure if it would be, a bit short-sighted to perhaps consider just a shorter plate, or to just go with a actually designed distal femur anatomical locking plate there.
Yeah, so I think for this one, I'd put an anatomical locking plate. What I'm trying to get across here is don't be afraid to use 2 devices. So trying to fit all 3 fractures into one device, you end up compromising your fixation and risking failure of either non-union or displacement of the fracture or malalignment. And so but there's no right answer with these cases. And so that's why we're just discussing the more complex femur fractures. There are some units that may consider using a distal femur, a retrograde femur nail with a DHS here. You have other devices like a lateral attachment washer, which I'll take you through later, with the periprosthetic fractures, which you could potentially use. So there's no right answer here, but the cover-up test for me kind of allows me to think separately. If I had this fracture, how best would I allow it to unite, and what's going to be best for my patient's function and mobility? And so what they've done in this case is an antegrade nail with fixation up the neck and a lateral locking plate. But as I say, there's no right answer. I just like this approach. And certainly where you can use one device and it's still the gold standard, you certainly should. So for the top 2 fractures you have, where you might in isolation use a DHS. Right.
Okay, great.
Right. Is Salma online tonight?
Hi, yes, I am. Good evening.
Okay, fine. Right. So we're on to, we've gone through segmental femur fractures, and I encourage you to read that article and ask a friend when you have these complex cases. So we're moving on to the next case. Do you want to just tell me what you're seeing and how you're going to fix it? Again, this is a 40-year-old involved in jumped off, fell off a ladder, isolated right femur injury. She's hemodynamically stable, ATLS is sorted.
Okay. So AP and I think oblique and lateral views of the right femur. There is a right subtroch femur fracture. Comminuted basically. There seems to be a butterfly segment there medially. It is displaced on that lateral aspect. Fixation wise, this patient would need a cephalomedullary nail because it's a subtroch femur, and it's going to be a bit difficult because it's comminuted. Getting that rotation right in the length is going to be the main issue. And for this patient, I would have, what is it now? I will not delay having to open if I see that I cannot reduce the fracture close. So I may want to open that fracture site and clamp it or sucklage it and then put a nail through. Because I think that's going to be the main thing. The fracture reduction in the length for these subtrochs. And then rotation is mentioned.
Good. So we see these often. Yeah, that's great, Summer. It's just a relatively straightforward subtroch fracture, but whenever I see a subtroch, I get my heart rate goes up just a little because these are tricky fractures to fix. So important that you look at your setup, that you're aware of the difficulties that are potentially there. So you've got to look at your entry point, the deforming forces of the fracture and the muscle pull, your patient's habitus, and your reduction technique. So we're going to go through all of those now. Thanks, Summer. You can turn off your mic.
Okay.
All right. So by definition, the subtrochanteric femur fractures are distal to 5 centimeters distal to the lesser trochanter. And obviously these are important things to go through, but practically it helps you with your reduction. The muscles are the deforming forces, and the big muscles around the fracture are what make it so difficult to reduce. You get external rotation from your external rotators. Abduction, so this is the proximal fragment. Proximal fragment externally rotates, abducts, and flexes. Abduction is from your glute med and minimus, and your flexion is from the iliopsoas as it pulls on the lesser troch. And so when you have a lesser trochanter fracture that's floating off on its own, sometimes that significant flexion that we find so hard to reduce is less so because your iliopsoas is not pulling on the actual main fragment. And then in the distal segment, you get varus, adduction, not addiction. Apologies for the spelling error there, and shortening. And your adductors insert on the medial aspects of the femur, causing that varus, and then you get shortening, and sometimes pull on the distal fragment from the gastrocs, which displaces the fracture too. All right. So there are a number of reduction techniques, and it's important not to keep using the same one over and over again, because you'll find one day that you can't actually get the reduction technique correct. And so this paper, which is a good review paper on subtrochanteric femur fractures for those of you writing exams, just goes through all the basics, pretty quick and easy read. But essentially what they did was they took cadavers and used pretty similar fracture patterns to show you the different types of reduction techniques that you can use. If you look at the top left, they've used a reduction clamp. Those are similar to the pelvic reduction clamps that we use. So remember, if you're on your own and you don't have a good assistant who's going to hold that fracture reduced for the whole case, think about other reduction clamps that you don't often use. The collinear clamp that we do have at Critiscare, but you can get from companies, is also a very powerful tool, especially with your spiral and shorter and your oblique fractures. Hold the reduction throughout the course of your operation, making your life a lot easier. The other thing is, when you use a reduction clamp, always go back and check your reduction, because you can ream and knock that clamp and lose your reduction, and then you end up starting with a really nice x-ray and ending up in tears. All right. The second set of x-rays, they've used the reduction finger tool. In the initial x-rays, they've used it just to get the entry point. So you can leave the fracture unreduced and get your entry point. And then with either polar wires, or like they've used the cob here in this x-ray, if you can see over here, to hold the reduction, and then pass the finger over the fracture and continued with the surgery. Now, the problem with that is, once you have taken the finger out and you've just got a wire in the shaft, you sometimes get displacement, and you can ream so that your nail doesn't fit in that same canal, in that same tract, and end up with a malreduction again. Remember, those muscle forces are pulling on the fracture the whole time. And this set of x-rays, they've used polar wires, or you can use polar screws to direct the nail to where they want it to go. Now, I must admit, this fracture is not significantly displaced. And so you've got to have some form of reduction before you put a wire in to guide your nail, and so that you don't end up in varus. But they are all tricks to consider when you're doing the reduction for this. Right, so we're going to talk about surgical approach and patient positioning. Your entry point is key. You want to err more medially. Although the design of the nails is a lateral entry, you want to err more medial, otherwise you end up with varus. You can use the traction table. And more I'm using the lateral position for these fractures. And I'm going to go through setup and x-ray for doing a lateral medullary nail. It sounds difficult, but really it's so simple. When I started doing it, it made me think, I don't know why I haven't been doing it all these years, especially in those patients that are larger. And with these types of fractures, are just, you put a patient on traction, you actually worsen those deforming forces because you're pulling on those muscles. And so sometimes you're fighting that the whole operation, whereas in a lateral position, you don't have those forces pulling on the leg. Have a low threshold for opening the fracture, like Salma said, and consider your assistant. These are not cases to do in the middle of the night or at 2 in the morning. You want somebody who has experienced hands, if you have them available. And if not, then you need to think about other tools that you can use, like the collinear clamp and pelvic trays and things like that. You've got extra tools at your disposal to hold the reduction for the course of the operation. All right. So I'm just going to quickly run through the lateral position for femoral nailing. Very similar to a hip But just a few things to consider. You want to make sure that your bolsters are outside of the way of the X-ray. Ideally, you want to be on a radiolucent table, but you can, on our standard tables, move the patient to the edge of the bed. Make sure you screen before you drape them, because you don't want to end up in a position where you can't see what you need to see. We do have bolsters that you can use that are outside of, this is a very nice one that's got a lot of levers, but some of our bolsters you can use just to hold over the pubic symphysis so that the top of the hip is free, and then one at the back. And you don't have to put them in as rock solid as you do with a total hip replacement, because you actually want the leg to be able to externally and the pelvis to rotate a little bit to give you a better X-ray. That's not going to change your reduction, so you don't need to have them completely stiff. The other thing to consider is making sure that they're not adducted too much, and that's more when you're putting in your distal locking screws. It becomes quite tricky with your X-ray. So you can consider a single pillow here. There are bone foams that you can use, and specific cushions for the lateral position, or you can use when you've gotten to the end of the operation, you want to do the distal locking, you can use gown packs and things like that. The benefit of this position, and I'll show you the lateral just now, but as you can see, when you put the patient on traction and you're fighting their chest wall and all the adiposity that sits up here, you are able to come in nice and easily in this position for your entry point. All right, so the next thing is just your AP X-ray. Really pretty simple. Make sure that you've got a sterile field for when they come through, but you can easily get an AP. And before you start, X-ray the other side just to see what the normal anatomy looks like. It's always nice to go back to. But as you can see here as well, the unaffected side is flexed forward, and the other leg, and you can have it the other way around, whichever's easier. But obviously you would potentially want this one closer to you as operating surgeon. And you can see this guy's quite skinny, but if you have a patient with increased adiposity, your glutes and the sort of thigh falls away from you. And again, that's a huge advantage. And you can easily reach the lateral side to open reduce should you need it. Your assistant does need to give some traction. So an experienced pair of hands is always more beneficial. And then this is your lateral. Now, obviously your femurs are overlying each other, but again, you have the bottom leg flexed forward, and the femur that looks the smallest on the view is the one that you're looking at. And you can always you can rotate the leg slightly internally or externally to give you a better lateral view, and take the one hip away from the other when you're putting the screws up the neck, which is what everybody's concern. And then you can also just slightly turn it off from 90 degrees to give you to accommodate for the anteversion on the femoral head, but really not too difficult. All right. And so I would advocate that you start doing them in lateral. I find it much easier, and happy to do them with you if you find a case you want to do, and I'm around. All right. I think Johan's online, hey? Kim.
Hi, Kirsty, yes,
Yes, all right. What do you want to tell us about this X-ray, and tell us how you're going to fix it?
Yeah, so distal femur fracture, sort of oblique in nature, the metaphyseal diaphyseal junction with extension intra-articularly distal, some comminution of the fracture with the metaphyseal junction there. Articular reduction is not too bad, and on the lateral there doesn't seem to be a sort of Hoffer type extension to this fragment. So yeah, dealing with a distal femur metaphyseal diaphyseal fracture with intra-articular extension. My approach would be to do a open reduction internal fixation with a lateral distal femoral locking plate, specifically looking at anatomical reduction of my articular surface, and then extending it's going to be quite a long plate to get adequate working length, but I think, and then just focusing on your reduction of that proximal fragment to get that as best aligned as possible.
So for me, I think what's important with any fracture extending into the joint is that you get further imaging.
Of course,
this one looks like a fairly simple, and this is what you'll be given in the exam, and you can make a decision on your surgical plan because you may not have access to a CT scan. But I think when you've got a partial articular or complete articular fracture, and you have access to CT scanning, it's best to do it because it allows you to plan better, as it would with a tibial plateau. So I haven't operated on a tibial plateau without a CT scan for years, but we tend to do it in other areas, and I'm not entirely sure why that is, when our objective is anatomical reduction, which you quite rightly said. So I like your plan. I think what you've said is great. I would just always say, when you've got a fracture around a joint, you would like
to get further imaging. No,
yeah.
Thanks.
So in this case, we don't have further imaging, and I would agree with your plan, but we're going to talk a little bit about the nuances around fixing these fractures. But otherwise, great answer. All right, Johan, thank you. So, oh gosh, losing this. Right. So principles for fixation are as for all articular fractures. You want anatomical reduction of the joint surface, mechanical alignment, stable fixation, an infection-free fixation, and early range of motion and mobilization. If you guys take a photograph of that and you say that about your approach to all fractures, one, it buys you time in the exam, and two, in real life, you go back to basic principles, you're going to treat the fracture as it should be treated. In these fractures around the distal femur, neurovascular assessment is key, and ongoing repeated neurovascular assessment is important. We all know the neurovascular structures lie just behind the distal femur and can easily be injured in these types of injuries. Planning is essential, and for me, that includes further imaging beyond X-rays. And then you must consider both medial and lateral fixation. Now, I agree with you in this type, the fracture that I've shown you here, lateral fixation is probably going to be adequate. And we'll later on talk about when you should consider dual plating and what the current literature says about that. All right. And then, as you quite rightly brought up, you must always, in the back of your mind, consider the Hoffer fracture when you've got extension into the joint, and make sure you're looking out for it. I always fix the Hoffer fracture. If it's part of a complex intra-articular fracture pattern, I tend to fix that first and then go back to putting the block back together and then the block onto the shaft. So if you're going back to AO basic principles, you want anatomical reduction, so primary bone healing at the level of the joint, and often where there's comminution, secondary bone healing with the articular portion to the shaft. All right. Who else have we got online here? Skull Klopper.
Yes, Kirsty, hello.
Are you with us? You're
I am with you.
Space there, Skull.
Yeah, am I still on that mode? I can't even see
are.
Yeah.
That's all right.
I don't know how to change it right.
All right.
Yeah, so I'm looking at images from a CT angiogram, AP lateral and posterior to anterior view, as well as a axial CT scan showing a sagittal split into the articular surface, diaphyseal metaphyseal distal femur fracture with intra-articular extension, and comminution. I don't see any cutoff of the vascular structures or the popliteal artery. There seems to be some sort of artifact as well. I don't know if it's gauze tracings or if it's an open fracture, and there's gauze tracings that is causing an artifact effect on the scan. And there's just in terms of the fracture displacement, there's posterior translation with the distal part of the fracture in extension, and translated also in the coronal plane medially, the distal aspect. So yeah, to summarize, there's a displaced intra-articular distal femur fracture with comminution and a sagittal split into the joint surface. Yeah, and I don't know about the soft tissue status, but it's assuming that there's a concern of either vascular injury or of soft tissue injuries involved based on a CT angiogram.
Okay, so this is a 35-year-old isolated injury. It is open, but there's a closable wound over the lateral side. I'm sorry, the medial side, and there's no vascular injury. The angio is normal.
Yeah,
so what are you going to do for this? So essentially, patient's ready to go to theatre, wound is closable, and you're going to do definitive fixation here.
Okay, yeah. So if you're going for early total care and you're going for initial debridement and internal fixation, you take the patient to theatre, you position them just on a normal radiolucent bed, normal bed with fluoroscopy and C-arm imaging. You'll be able to, you already have a medial wound, which you'll debride and wash out appropriately. But the fracture configuration, I think, is amenable to a lateral distal femoral locking plate, the construct fixation, with the goals being anatomical articular reduction of the joint and mechanical alignment, and as close as possible to, or essentially anatomical reduction with relative stability and secondary bone healing.
Is that the only way to fix this fracture?
No, it's not. You can. That would be what I would think would be my first prize. The second option would be intramedullary nail fixation, or retrograde femur nail, but with careful reduction of the intra-articular split and the joint surface, and with screw fixation from lateral to medial or medial to lateral, out of the way of your nail, and avoiding fracture propagation when doing a retrograde nail.
All right, great. Thanks, Skulk. So yes, and plating is not without its complications. You know, you may have a greater exposure, so you can certainly do a MEPO technique with this. But the non-union rates with plating are higher than those with nailing, and so you should consider nailing. Now the problem with nailing here is your distal fixation and getting enough screws across the joint, but you can augment it if you want to with screws around. So you put screws or wires, cannulated screws outside of where your nail is going to go, miss a nail, and put your nail up. And so that's what they've actually done, or what I did in this case. Keep losing my ability to move on. And I spoke to you guys about this earlier. There are newer designs coming out with nails, and this is something called the lateral attachment washer from Depew Synthes, where there's this plate sits on the lateral side of the femur and gives you fixation across that articular fragment. And there is the option to put these screws through the nail. So if they go through the plate and through the nail, you've got essentially a mini locking plate on the side. And so we'll talk a little bit at the end, if there's time, or you guys want to, about why nailing is better than plating. in most cases, and just a biomechanical sort of description of why it makes sense to me to try and nail what you can. But certainly either of those two options are good. And I just brought this up because Dane, we had a case like this the other day in the Monday morning meeting, and Dane said, you fix this with a lateral plate, that's it. So there are other options, and certainly in my hands, this is a tricky operation because I'm not used to using the lateral attachment washer, and I would probably still go for a lateral plate here, but it's not the only option that exists. Okay, and less exposure, you get your patient weight bearing on this relatively early, and you've got that basically a massive washer on the lateral side that's holding your articular fragments together. Okay, thanks, Skull.
Cool.
All right, so on to atypical fractures. And again, this is not a talk about bisphosphonates or soft and hard bone diseases, but you must just be aware of fractures around the femur that occur because of these underlying diseases. Bisphosphonate fractures, I must admit, I see less and less of, but they do exist, and they're usually in the subtrochanteric femur, subtrochanteric area, so-called chalk stick fractures. Chalk stick fractures were originally described in the in the spine, but can be extrapolated into the distal femur. Hard and soft bone diseases, patients are more likely to fracture, and you must just be aware of the fracture patterns and how to fix them. Stress fractures in the femur shaft are very rare, but do occur. And so if there's concern regarding a stress fracture, the workup as you would for a neck of femur with initial x-rays and then MRI are important. You need to investigate and manage the underlying pathology. All of them have a higher risk of non-union, and so your principles that we've started the discussion with earlier are that your mechanical alignments and stability of fixation are extremely important, even more so than in the standard patient. So attention to detail with regard to those are very important. I see Dane's responded here. I would never say that's it. It's true. I was paraphrasing on your statement, but so I apologize, Dane. You didn't say that was it, but I just wanted to show you how to treat it differently. Right. Don't take offense. It wasn't a personal attack. Right. So, Dane, on that note, are you with us?
Yeah, I'm done crying.
It wasn't a personal attack on you. It's not something that we do. I just wanted to bring your attention to other fixation techniques. All right. Do you want to take us through this X-ray?
So we have an AP pelvis X-ray showing a right subtrochanteric femur fracture. It's atypical in nature in that it's transverse. Then the quality of the skeleton in general, there's virtually obliteration of the intramedullary canals, and the entire pelvis and all the bones I can see virtually have are very what's the right term? Very poor penetration, implying increased density. So I'd be worried about a disease along the lines of osteopetrosis in a case like this, with now an I suppose you'd call it a pathological fracture of this right femur, as I'd mentioned. So the concerns here is the lack of a medullary canal, where you would ideally fix this with an intramedullary device under normal circumstances. So, I mean, priority would be to make a diagnosis if the patient is not already known with some form of bone disease, and then plan your treatment thereafter. Is there any history or known condition?
Yeah,
into
so
the osteopatry?
He's got hearing, he's got visual impairment and hearing impairment.
Yeah, so
his stature, and he was complaining about preceding hip pain.
Okay, so the loss of those cranial nerves is in keeping with osteopetrosis. As the cranial nerves pass through their bony canals, they also get squashed, basically, as they pass through their anatomical pathways, and then the short statures again. So I think I would, without a bony biopsy or anything, confirm osteopetrosis in this case. So as I'd mentioned, they lack intramedullary canals. So I believe it is still possible to fix this with an intramedullary device. However, you need solid reamers and you need to plan appropriately. Alternatively, it could be fixed with a plate. However, proximal fixation is going to be, you might struggle with proximal fixation as there's not a lot of space proximal to the fracture before you reach the hip joint. So those are my two options.
And when you say plan appropriately, what kind of planning are you?
Well, I mean, it goes without saying that you wouldn't do this in the middle of the night by yourself. Ask a friend, etc., as you had said. But yeah, in broad principles, I believe it is possible to treat these intramedullary devices. And another good reason to try and do that would be to avoid stress rises. So you could span the entire length of the bone with a nail a lot more easy than you could with a plate. But as I said, you need to fashion an intramedullary canal with solid reamers rather than the typical flexible reamers that you get with the standard nail sets.
And
alternatively, yeah.
Sorry,
you were saying?
What is happening on the other side?
You mean the other femur? Well, he's got a natural varus angulation. I'm now trying to scrutinize the neck or the proximal femur. If there's any sort of stress rises, it might be on the lateral cortex, just below the subtrochlear. Yeah, just there. That there's it's the term beaking of the cortex there, which it could be an impending sign of a stress fracture there.
So you've already said it essentially. He's got stress, essentially repeated stress fractures that's led to this pathological fracture, and largely because he's got a very varus neck. I mean, he's almost 90 degrees here on this side. So when you're fixing, what else might you think about?
You're talking about restoring a better neck shaft angle rather than his anatomical neck shaft angle. Yeah, so you could incorporate a form of, maybe osteotomy is not the right word, but restore a more anatomical or more physiological neck shaft angle. I'm not sure what the implications would then be with regards to his other side, because you'd obviously lengthen him or potentially lengthen him, I suppose, depending how you did it. So you have to consider that as well.
Exactly. So you need to consider taking him into more valgus so that you could fix him in this position and you end up with the same problem down the line. And then the other thing to consider is, do you prophylactically fix the contralateral side, and what do you do? So a very complex case, and I just use this as an example for this is a typical subtrochanteric, or not typical, it's a subtrochanteric femur fracture with all its complexity, the deforming muscle forces, with the addition of it being atypical associated with a bone disease. Now, this case, this is what was done. And as you can see, I haven't got x-rays of the distal portion of the femur, but essentially this is a pediatric nail, because reaming this bone destroys reamers and drills, and you can see there's a drill bit stuck up the neck. And I'll tell you that there was a reamer left, the tip of the reamer broke off and left at the distal portion of this nail, and the nail, the canal that was created was only about sort of 2/3 of the way down the femur. There just wasn't, that reamer got stuck and we weren't able to do any further. But as you can see, we've attempted a valgus osteotomy in this case, to try and allow for a better mechanical alignment and union. very difficult cases, and augmentation with this medial plate to try and get that apposition of the osteotomy site. One could say maybe that osteotomy wasn't, it could have been better compressed across there, but that was what was done intraoperatively. And we chose to, and again, sorry, I don't have the x-rays of that, prophylactically plate the side. And so because you are at the stage where you don't need to create a canal to prevent, so you're putting a plate to overcome the tension forces from the varus osteotomy. Because going in, as you can see, there was a lot of difficulty with this case, trying to put a nail prophylactically down the side. We decided against it, but just applying all the principles of femur fixation for the more complex cases here. Right, Francis again. We're moving on to our last topic here. Do you want to talk us through this x-ray?
Sure. So we have an x-ray of the right knee showing essentially a periprosthetic fracture on the femoral side of a previous total knee replacement. Just talking about the fracture itself first, it's just proximal to the implant. So it would be a STU1 classification. In terms of the implant itself, the tibial side is fine. Just looking a bit more closely at the femoral side, it's a cemented component. It appears to still be well fixed, not loose. In terms of the initial placement, it's a bit difficult to tell if it's because of the fracture now. Might have been in a slightly flexed position. Then the bone quality, relatively thin cortices on the femur. You can also see some generalized osteopenia in the proximal tibia. Yeah, and the fracture position, it's slightly displaced with a bit of apex anterior angulation or flexion, and a little bit of shortening. So it's a periprosthetic fracture with a well-fixed implant in possibly soft bone or possibly osteoporotic bone. So obviously the patient needs to be worked up in terms of host and osteoporosis. And then in terms of fixation, so I haven't commented on the kind of box with the implants. I think there would be room in the bone to allow for a retrograde nail, but I'm not sure this implant will allow a nail in and being a little bit more flexed. Even if it's an implant type that does allow for it, I'm not sure if I'd be able to place my starting point anterior enough. So failing that, I would use a locked lateral plate, but in a patient with soft bone, I prefer to use a nail or a combined technique to give more stability, so a nail and plate combination.
Great, yeah. So if this was the fracture, I would aim to nail it. And this is where that lateral attachment washer that I showed you previously on the distal femur case with the intra-articular split, these are the fractures that it was designed for. So nail it if you can. When it comes to these fractures, you can augment with other fixation. This is a really important article for you guys. Unfortunately, there hasn't been an update on the newer implants, but this is not really for exam purposes, it's for life purposes. So when you get a patient that comes to you through the trauma unit, find out what implant it is, get hold of your reps, and this really has a great table that tells you whether the box will accommodate a nail and how big the box is. And so you can compare that to what retrograde nails nails you have available, and important to look for nails that have multiple distal screw options in multiple planes, because obviously you're dealing with osteoporotic bone. But this is a really helpful article. So okay, so Francis, you've already gone away, but this is the same patient.
Oh wow, okay.
All right, so you don't have to go through what you're going to do. Essentially, we're going to put a plate on this
It's gonna
patient,
have to be a
but
plate.
always
All the way to the top.
age-old lesson that you teach your
X-ray
interns.
the whole bone.
Yeah, look at the top of the bone. So you can still nail if you've got a shorter prosthesis, but this uncemmented stem heads quite far down the canal. And so putting a retrograde nail, you're going to end up with a stress riser. And so I would definitely plate this one. And you must always consider the dual plating, which we'll go through now. All right, so there's increasing incidence in an aging population, and you guys and myself will see it through the course of our careers. Non-union rates are up to 20% with these fractures. And the reasons for that, obviously not all periprosthetic or fragility fractures have high non-union, that percentages with distal femur fractures. You've got the high energy injuries that have severe metaphyseal comminution and fractures that extend into the articular surface, and critical bone defects that all contribute to non-union. And then on the other side, we see varus collapse resulting in hardware failure, non-union. And so that's what I want to look at, is which of those fractures do you supplement with some medial fixation, because the femur will tend to drift into varus. And if you remember from the beginning of the talk today, or the discussion, is thou shalt not varus, because you're going to end up with issues, malalignment and non-unions. Osteoporotic bone increases your risk of non-union because there's insufficient implant anchorage and poor purchase of the screws. And then periprosthetic fractures, you've got limited bone stock for fixation of the screws. And again, the periprosthetic fractures are fragility fractures. They're one and the same. And so just going back to what we said about the atypical femur fractures, we've got to look at the patient as a whole and make sure you're doing a fragility workup, DEXA scans, that they're on bisphosphonate treatment, and you are chatting to your endocrinologist with regard to that. All right. So here are just some examples from this article about dual fixation with complex distal femur plate cases. And the two major options are your dual plating, medial and lateral plating, and then your nail plate combination. Now, there are no big randomized controlled trials saying whether dual or single plating are sufficient for distal femur fractures. And so you've got to look at each fracture on its own merits. For me, if there's medial comminution, if there are large bone defects, or if I'm concerned that there's potential for non-union, I tend to put a medial plate on too, because, and you've got a long working length, as you can see in this case, because you don't want to end up with that varus collapse and non-union. You can put your medial plates in MEPO. Now, the hesitancy has always been not to put a medial plate because of your neurovascular structures around the distal femur. And so what I do is I tend to err more anterior medial with my approach to the distal femur, and sliding. If you slide the plate, so you use your Bristow to slide the plate, or you use your Bristow to create a plane that heads more anterior than it does posterior, then you'll miss your neurovascular structures, which are obviously at risk when you're putting in a medial plate. And you can see in this on the second X-ray, where there is medial comminution here, there's a large fragment. They've opted to go for a nail with a lateral plate to supplement and increase the stability over the fracture. but each fracture must be treated on its own merits, and there's no standard of care to say if there's this amount of, not like your proximal humerus fractures where if there's this amount of medial comminution or this amount of bone loss, you should consider a medial plate. Hopefully, with the current studies that are ongoing, we'll have a little bit more information, or more data to guide us with specific sort of measurements and when to use a second fixation device. All right. So take-home messages. Segmental fractures, we're looking at the cover-up test and assessing each of the fracture patterns. And the mechanical alignment is imperative for union. So alignment. I think I've said it enough tonight. So subtrochanteric femur fractures are daytime cases in my books. You need to have multiple reduction techniques in your armor and consider the deforming forces of the muscle. Look at alternative positioning, especially if you've got a tricky patient. And then periarticular fractures, we looked at anatomical reduction in alignment. And our fragility fractures, we looked at considering dual fixation. Right. The last thing you are welcome to ask any questions if there's anything you want to ask me now, but I just want to go through, I've put this picture here because I only recently sort of cemented in my head, if you want to call it, why a nail is better than a plate. Now, it's because of its on-axis, on-axis loading that you have. So the differential for me is, if you want to take it into a real life situation, is these ladies carrying water from the tap in a rural village will put a bucket of water on their head and carry it for kilometers to get back home. Now, if they were to take that same bucket of water and carry it out in front of them, they would fatigue far quicker than they do with it on their heads, and that's because it's running through the axis of the skeleton. The same is true of a nail. If you've got on-axis fixation, as you all know, the race for union is against the metalwork. And so if you've got a plate that's hanging onto the bone like this, more likely to fail, whereas a nail, which is on axis essentially through the axis of the bone, will hold for longer, and so has a greater chance to union. And so that's why where you can nail a femur, because the forces and loads going through your femur during your normal gait pattern are rather large. I just like this analogy in the picture of on axis versus the plate that holds on from the side. All right, has anybody got any questions?
Kirsty, maybe just if I can maybe just ask one thing that just to make sure that I'm understanding it correctly, that with the dual plating, the way I sort of understood it was if it's an oblique fracture, but the proximal fragment or the angle of obliquity is essentially higher on the medial side proximally, if it makes sense. The fracture goes from proximally medial down to, no, sorry, other way around. It goes, other way around, yeah, other way around. So if essentially with weight bearing, it's going to want to sort of shear off on the medial side, where obviously if you do pure lateral plating, there's going to be nothing giving an anti-glide sort of effect there. Would those also be, apart from the ones where comminuted, where it's advocated for just a small plate, maybe just in that, to key in that apex there, or?
Definitely, yeah. So the reverse obliquity, certainly you could dual plate it. You can also consider a nail plate technique, because that's going to stop your shear forces. But yes, absolutely, that's definitely one to consider, and I haven't included that in this discussion. So yeah.
Okay, perfect. Thanks.
No burning questions.
Chris, can I quickly ask you just a quick one?
Sure.
Sorry, my name is Samsung on the thing. We're still target plating our gunshots, neck of femurs, right? We're not, because they fail with DHS and stuff. So I've been out the loop for some time. We're still doing that.
It depends on the neck of femur and the amount of comminution. Some of them we will go to a primary total hip replacement. So that's yes.
Another
If
topic.
they're relatively undisplaced and we have a risk of, and they have potential for union, then we're using sort of fixed angle device like the target plate. But some of them will consider primary arthroplasty because the outcomes are better. And yeah, so we'll be publishing on that soon. But it looks like for the very complicated fractures that you cannot achieve anatomical reduction, total hip replacement has better outcomes for the patients.
Thanks.
Sure. All right, cool. Welcome to email me or come find me if there are any questions that you didn't want to ask in front of everybody else. And if you want access to those articles, I'm very happy to send them on to you. So just let me know. All right, cool. Thanks, guys.
Thanks, Kirsty.
Thanks, Kirsty.
Thank you, Kirsty.
Sure.
Thank you.
Cheers.